Yeah,
Thank you for the respected chairperson. Thank you for the introduction and thank you for the organizers for inviting me. So today I'm going to discuss that whether monitoring of the adverse breast cancer with liquid biopsy can we demonstrate clinical utility. It was initially presented in ACBCS Conference 21 by Dr. F.C. Vidat from Institut Curie, France. And we know now that the breast cancer treatment is becoming more and more individualized, and liquid biopsy is one of such tools in the armamentarium of the precision medicine. And it is a minimally invasive tool where we detect the ctDNAs and also the circulating tumor cells that are released from the primary tumors and the metastatic tumors to the bloodstream. And thereby, if the CTC counts are rising, we can detect the early relapse of the tumor, which opens up a new window of opportunity. Also, the ctDNAs can be analyzed for tumor-specific mutations that are responsible for treatment resistance. So as the tumors are evolving over time, the real-time assessment of the tumor dynamics help in monitoring the treatment efficacy. But does doing all this, we prolong the survival of the patients or we delay the progression? It need to be seen. So the clinical utility has to be seen in clinical trials. So I'll be basically discussing my topic on these three broad headings and will be emphasizing my talk on two important trials which was presented in SABCS 21, that is CTRACT-TN trial and also the PADA-1 trial. Next thing is that the CTRACT-TN trial, the background is formed by the fact that ctDNA can help detecting the metastatic relapses or the relapses much earlier and be much earlier than that is predicted by the symptoms or by doing imaging. So this gives us a new window of opportunity. And if we intervene in this window of opportunity, does we have a clinical benefit to that? If we give a rescue therapy immediately, does we have a clinical benefit to that? So this is the CTRACT-TN trial. It was conducted by the Turner and his group, phase 2 multicentric trial. And it is conducted in moderate to high risk non-metastatic triple negative breast cancer because they are at high risk of developing relapses more higher than the other subtypes. And following the primary treatment, they underwent an active ctDNA surveillance at the baseline and 3 monthly. And those who were ctDNA positive within 12 months, they were randomized either to observation or to interventions. Now, 208 patients were initially included, and after 12 months, 52 patients were ctDNA positive. And those underwent randomizations. The patients who underwent into the intervention arm, 70% of the patients were found to have metastasis by imaging. And they were too late for the rescue therapy. Only 4 patients were started on the rescue therapy, which was pembrolizumab. So the results of the CTRACT-DNA trial with a median follow-up 20.4 months shows that the proportion of ctDNA positivity by 12 months was much higher in the high-risk patients group. But at the time of ctDNA detection, a relative high rate of undiagnosed metastasis was there, which was detected in the imaging. So the interventional arm, that interventional therapy, didn't show any potential activity. But this trial had some implications for future trials. That means starting the ctDNA testing earlier in adjuvant setting might help, and more frequent testing might help. Also, using of more sensitive ctDNA assays to track the variants will be helping. And therefore, the CTRACT-DNA trial, it can form the basis of the future trials. So other trials which are being conducted in the advanced breast cancers are actually advanced breast cancer without having symptoms or radiological evidence of disease progressions are Persevere trial, Artemis trial, ZEST, Aspiria, and their TRACT-ER trial. Of this, the ZEST trial is a phase 3 trial which is conducted in BRCA positive BRCA positive group, TNBC group, and late rescue therapy with niraparib was given. So next thing is whether monitoring this breast cancer patients who are having overt advanced disease helps. Now, the answer from this question comes from the STI-CTC trial, which is conducted in 778 patients of ER positive, HER2 negative breast cancers. And this trial was conducted in the pre-CDK4 inhibitor era. And this trial was looking at whether CTC-driven treatment choice was non-inferior to the clinical-driven treatment choice. So here, the hormone receptor positive, HER2 negative patients were then randomized to the standard arm or the CTC-driven arm. In the standard arm, the patients received the chemotherapy or hormonal therapy based on the clinician choice, which is actually based on certain clinico-pathological prognostic variables. And in the CTC arm, they received treatment according to the CTC levels. That means high CTC levels are going to get the chemotherapy, and low CTC level, they are going to get the hormonal therapy. Primary medical endpoint was the progression-free survival. So the result of this study showed that the CTC-driven treatment choice is non-inferior for progression-free survival in metastatic breast cancer in ER-positive HER2 negative setting to that of the physician-driven choice. But more importantly, they find that in the discordant group, where the CTC levels were high, but the clinical risks were low, the PFS were longer with chemotherapy, and in those subgroups where CTC levels were low, but the clinical risk was high, the PFS was not shorter with endocrine therapy. So also this analysis of the recent unpublished study shows that similar trend was found in OS also, but it should be taken with caution because this study was done in the era where before CDK4 inhibitor era, and also we should say that this CTC driven choice was not based on the primary analysis was not based on the OS, but it was based on the PFS, so it was not adequately powered for OS. And second important thing is that the CTCs can also detect the primary resistance in a way that if the patient is continuing a line of therapies and there is lack of early decrease of the CTCs, then we can say that there is a primary resistance, and then we can shift to the second line therapy. Some important trials are undergoing, some trial results have already come. One such trial is the SWOG 0500 trial, where switching to the second line therapy was tested, but there was no gain in the survival. Another trial which was conducted based on the same thing showed a poor compliance and slow accrual. There are some important trials which are ongoing, that Mondal trial and Sapphire 03 trials. Another important trial which has to be discussed in this point of view, and also it has been discussed in this SABACS, is the detection of the secondary mutations, secondary resistance to the endocrine therapy by detecting, does it have a clinical utility or not. So the study is the CATA-1 study. Now we know that ESR1 mutation is associated with endocrine resistance in those hormone receptor positive advanced metastatic breast cancer. So in metastatic breast cancer who were hormone receptor positive, HER2 negative, and who were on the first line therapy with AI and one of the CDK4 inhibitors, they received they underwent ESR1 mutation detection testing serially, and if there was no synchronous progressive disease, then they were randomized to continue the same therapy or switching off to the fulvestrant plus palbociclib arm. And the results, which were early results of 26 months follow-up, showed that switching to the fulvestrant and palbociclib resulted in a doubling of the PFS almost. And those patients who continued in the AI plus palbociclib arm, they were allowed to cross over, and the second line PFS came to be around 3.5 months. So this was the first study to show that change in the first line therapy in hormone receptor positive metastatic breast cancer based on the resistant tumor marker rather than the imaging confirmation of the progressive disease have a clinical utility at present. And to conclude, I will say that disease monitoring helps open a new window of opportunity. When metastases are still asymptomatic, we can escalate the adjuvant therapy. We can give earlier rescue therapies. The prognostic assessments help in harmonizing the treatment decision, and it also helps in the response monitoring. More and more clinical trial has to come up to prove its clinical utility. And my take-home message is that from what it is, CTCs and ctDNAs, they are definitely validated independent prognostic markers. But from PADA-1 study, we have seen that in the endocrine resistant setting, particularly using 1/5 line of therapy, that means giving another therapy when the ESR count, ESR mutations are detected, it opens in the new window of opportunity. It provides a gain in the PFS. This might not catch up when we wait for the progression and give second line therapy. Also, that the CTCs, DNAs, CTC and ctDNAs, they are reliable and reproducible biomarkers for guiding treatment choice in first line hormone receptor positive. Also should emphasize that the design of the clinical trials based on the biomarkers, it has to be something different from the acceptance will be later, but we also need to incorporate the cost analysis, cost benefit analysis as one of the endpoints of these trials. And so we are at the dawn of the personalized and precision medicine. A lot of more things are going to come, and then we can say that there are clinical utility and we accept it in our general practice. Thank you.